away because it's going to slide for sure. Where's the lights if I just want to do something dramatic before we start?
It's with great pleasure
just about 2 minutes
that
and I'm going to turn it down a little bit and then I'll
next
turn it back
speaker,
up.
our first one for the afternoon. Dr. Bartram comes to us from Australia, Adelaide, Australia. Right? Or Australia, but where? Where you practice where? You need to tell me. Where? You can tell him. He graduated in 1971 from the University of Adelaide in Australia, and then in 1972 to 1982 he spent 10 years in London practicing dentistry and being a researcher. He obtained his he got his acupuncture license there. He studied homeopathy and got involved with a lot of electroacupuncture according to Boll during that period of time. By 1986, he was ready to take his show on the road, and he went back to Australia and again continued to be a leading researcher using all of the electroacupuncture material that he's learned from all the greats who are teaching this material or have taught this material, neural therapy, low-level laser therapy, and again, he is a farmer, I gather. He raises Scottish Highland cattle, and he's lectured extensively on the different continents on low-level laser therapy. So it's with great pleasure that I introduce our first speaker this afternoon, Dr. Bartram from Australia.
Thanks very much. Can we do a test on the sound? That okay? Everybody here? Okay. This one as well? All right. What about the throat mic? Sounds good back there? Okay, good. Alrighty, thanks very much, Ed, for the invitation. It's wonderful to be back. It's nice to be up this side of it for a change. I always feel that when I come over here, everybody thinks I'm the one that's got the accent, but little do you blokes know, you're the ones that have got the accent. I'm the one that speaks properly. What I will do, though, is that if I do tend to get on with things, so if you find that I'm going a little bit too fast or I'm using expressions you don't understand, for goodness sake interrupt me, because it'll just save you going along and not knowing what's going on. I've just been down to Mexico for a week, and I thought actually I'm going to present things today. I'm going to cover about 8 lectures in about 1 lecture, so I'm going to try and pack it in. So I know everybody wants clinical stuff, and we'll get to that. And if I seem to be going too long with anything, for goodness sake, tell me. We only got a certain amount of time, and my view is the floor is now open, so that if I'm going through things and we want to discuss them, push them a little bit further, we don't get a lot of chances to get together. So let's explore it as we go. Low-level laser is fantastic. I think every surgery should have one in every surgery in the practice. We use them on every patient almost, so it's great. But I was coming back from Mexico, and of course I took a laser down there in the luggage, and the first thing I found was I arrived, and within about a day or two I had gastroenteritis, as everybody always gets. So I had the laser out on the acupuncture points, colon 4, stomach 36 and so on. Then a couple of days later I had a overexposure to the sun, so I had the laser out on the skin, soothing down the suntan, and then my brain was recovering from being stressed by no sleep, jet lag and all the rest, and I chomped a bit out of my lip. And the next thing I knew there, I needed the laser on the ulcer, the traumatic ulcer I just created. So I figured I should actually do the initial lecture on Mexico and how to survive without a laser, I think. Now, what we'll do is everybody, who has actually seen a laser here? I always find when I talk lasers, there's a presumption that actually everybody knows what a laser looks like. Who's actually seen a low-level laser? So about a third. That's it. Yeah, okay. So let me show you. Ed's been good enough to let us lend his P laser today. This is one of the handheld types. I've got some slides of some others. I've kept the slides down today to one container full rather than about 3, so we don't get too long in drawn-out discussions. But so every slide is important. But I'll show you a couple of other types of lasers later. But this is a P laser. This is one made in Denmark, and that's what they look like. And if you haven't seen one working, can you just turn the lights down just a little bit for a second? This is the sort of appearance that you can get. This is your red lasers, so you can actually see them actually working there. The actual infrareds are much, thanks Ed, are different. Okay. Now what I'm going to do, these are soft lasers of course today, everybody knows that. These are not the hard lasers that cut everything. This is the soft laser that is more biostimulatory healing. And what I want to do is I'm going to sort of flit a little bit. It's going to be like one of those trips around Australia for about 2 weeks, you know, Sydney, Melbourne, Outback, Opal Mines, perhaps a quick trip up to Cairns or something like that. Adelaide down for a bit of wine down there in the Barossa Valley if you're lucky. What is laser light? What is a laser? Types of laser. That's, for all you guys that use lasers, you'll probably be a bit bored with me just running through some of these things. But I think it's important that everybody's clear on some basic information. So I'm going to run through those and I'll go through that quick as I can. Then whenever you go to a lecture or they're trying to sell you a laser machine or something, invariably what happens is you get your basic lecture centres around here. It goes, what's a laser, types of laser and so on. It misses this biological effects. They avoid this because the average guy just doesn't want to get into why lasers work, how they work, what the possibilities are. And they usually switch straight down to clinical effects and they'll say these are the 7 or 8 clinical effects, lymph drainage, increased microcirculation. They get into that and they avoid all this. And then they centre down on the dental treatment and they spend about an hour and a half with about 200 slides and they say here's a surgery, here's before, here's after, here's a herpes before and after. And they'll run through all the time on clinical cases and suddenly your time's up. Well, I don't mind doing a little bit of that today, but I want to spend time here too. And this is a tough area. So if you find it's tough, well, that's the way it's going to be. But it's just one of those areas. There's about 6 or 7 major concepts behind why lasers work, and I think that you got to be in there. The musculoskeletal and the interference fields, I lectured at the big world conference last year on interference fields for about an hour. So today we've got about an hour and a half and plus this demonstration at the end. So we're going to have to keep moving, and I'm going to have to sort of just run through things fact by fact a little bit. We've been doing a lot of research in South Australia. We're doing a lot of work now with newer types of lasers, pulsing, anaesthesia, a whole lot of concepts. We've just actually established I'm one of 3 people on a world patent for using homeopathic oscillations in laser beams. It's pending now. So this is a real new area, and it's not probably for today as such, or probably for the next couple of years till we sort out exactly what the limitations and the possibilities are. But I want to get into that today just to tell you where we're going and what may be happening tomorrow. So I think, and then the demonstration, I want to just get somebody out here who's had, say, their mercury fillings or their heavy metals out of their mouth. They've detoxified. They've maybe had some retina cavitation therapy, maybe if they needed to. They haven't got any root canals. I just want them to sit in here. I want to run down all the acupuncture points that relate to the various areas on the jaw, all the lymph points. I want to use the laser in the way that I use it in my own practice to completely clear interference fields, and we'll do that, and then I'll just show you how quick it can be done. And I'm sure that everybody's probably to some degree familiar in all this sort of stuff anyway, but I just want to show you how we do it. And it's taken us about 3 years to work it out, and it works really well, and it'll be a lot better if I show you in practice than talk too much, because you'll see how it manifests. And so we're going to bring an EAV machine in somewhere. We're going to have a patient here, somebody that's not me. I'm going to tell them how to use the laser on the acupuncture points and on the various areas, and we'll go from there. And should be pretty good, I think. Hope so. Okay, now I've got some little bursts of slides. They sort of go, I kept them to sort of 6, 8, 10 at a time. I'm going to go through a section, then I'm going to run through a couple of slides, through a section, run through some slides and so on. Let's go. So characteristics of laser light. What is laser light? Okay, so what I've done is I put down 4 major points for them. Now what I sometimes do is I actually give out notes, and Ed's actually got some of the stuff that I presented to the university earlier this year. But there are 4 points that go with a light being classified as laser. Number 1, it is a single wavelength. It's monochromatic, or very close to it, most of them. Number 2, the wavelengths are coherent. They're all in line. They're like soldiers lined up. That's not a good example, but the third thing is that the light is unidirectional. It's in a beam. And the fourth thing, which is, I suppose it's the first three of the major ones. The fourth thing is what's called outstanding luminescence. No questions on that? That's all pretty straightforward, I think. There's a very good book by Curtin Rose that has a lot of this introductory stuff in it. I know the Academy's got them. I just saw the new soft-covered versions are now available, and I was just at the Australian Medical Acupuncture Conference before I came over, and there's a new book as well now out from a Finnish professor that also is on low-level laser therapy. So we're starting to get these at least dentally orientated. It doesn't get into interference fields or anything, but at least they're getting to cover a lot of these initial facts. Okay. Beam types for lasers. As far as beams are concerned, you can either have a beam and a laser which is constant, so you get a constant power being put into the tissues, constant energy put into the tissues, or you have a pulsed beam. Almost all dental lasers up until now have been made with constant beams, with continuous beams. And so if you had a chart, you have a power on the vertical, you have time on the bottom axis, the power remains as a horizontal line over a period of time. You can actually, if you have a constant laser, you can actually manipulate it electronically, so you can actually chop it up so that instead of the power being in one long line, you can chop it into square sections over a period of time so that you can actually pulse it, what appears to be pulsing, and you can cut up those pulses into shorter long. So it can be pulsed even though it's not actually a real pulse laser. The proper pulse lasers have a gap and then they have a spike, or they can be certain lengths. It doesn't. The width of the pulse can be a certain width, and they'll have a spike and then gap, spike. So they are genuinely have an individual output. Okay. So the beams can be either constant or they can be pulsed. With the pulsed power, the other point about them is that you get very high points and then you get nothing for a while. Then you get a very high point and nothing. And what happens is that, so when you average out the amount of actual energy entering the tissues, it might go in as a thump, gap, thump, but the actual average energy is fairly low, even though the power might be quite high initially. So whereas with constant stuff, it's the same all the time. Now, there's a couple of other little points that I just want to get out of the way before we get into it, and that is that you have dosages, effective total dosages, you have expressions of power. All these, for people who don't understand lasers, are really quite important. Now, first thing is you have an output of the laser. The laser is putting out a certain amount of energy. How many photons? You'll hear this word photons over and over again today. It has an output of these photons, and the energy of the actual the laser, as per the output times time, is measured in joules. So you'll hear this word joules, joules, joules. All treatment that we do in our surgery, if I tell a nurse to do treatment, I say, give that apex 2 joules, 3 joules of energy, whatever. And we set up when we designed a lot of the equipment, we set it up so we could switch a knob that would give a certain number of joules for a certain treatment. So joules is the first thing. Energy in joules equals mean power in watts times time in seconds. The other thing is, and the other critical thing is, that depending on the size of the tip of your laser, it depends how concentrated the beam is. Now, you can get a stiletto effect. The smaller the beam gets, the more concentrated. You can get these collimators which can narrow the beam down. You can get higher powers per square centimetre. Now, there is a cut-off point at which the power gets too great and it could damage tissue. Now, that's about 500 milliwatts per square centimetre. So if you get a laser, number one, you want to know your outputs, but number two, you want to know what your wattage per square centimetre is at the tip, because if it's too high, you might cause some damage. And if you're designing lasers, the same thing applies. Now, when I was in Adelaide, there was this guy showing off. He was doing a demonstration on a new type of laser, and I'll tell you about it in a little while. but he had quite a powerful diode that he'd focused down to a point, and he brought out some black foam and he put the laser on it. Now we're talking about 100 milliwatts, that's what we use standard in our clinic, and he had it focused down, and within about 3 or 4 seconds there was smoke coming out of the foam. So anybody that tells you that 100 milliwatt lasers or any of these other ones aren't dangerous, they sure are if they're not, and particularly if you shine it at somebody's eye. The retina has a varying capacity to actually focus the beams of the laser, either the reds or the infrareds, and the lens will focus it on the retina, and if it focuses a normal beam onto the retina and you get a pinpoint resulting, then you will damage the retina. So all these guys they sort of say safety, yeah, sure, safety's a prime concern, don't shine it in the eyes, you better not. And what we do in Australia now is I make sure, as part of my training for the nurses, because they end up doing a lot of your work, you get them to make sure they've got these protective specs on all the time. And even for themselves, because it can reflect back off something. Well, you can believe how stupid people are. I mean, but people, sometimes they just look at the beam. Quite, they just almost, they want to see something there, and it's just happens. So you got to be careful. Okay, so effective doses. There's just one other minor point I can include in this initial wrap up, and that is that your dosage is the effective dosage will also be determined by where you put the laser per where the problem is. Now, if you hold it away off, the beam will spread a little bit. If you want to get the best results, put the laser tip on the tissue. If you've got a problem underneath the tissue, put the laser on the tissue, and then you haven't got much refraction, and all the rest of it. So, contact your tissue. Contact that. Okay. Now, what I've done as well is that laser, see it as light. See it as the same things happen with laser light as with any light. So when it hits tissue, you get reflection, refraction, absorption, spread, and transmission. Now all the things may or may not lose your laser. So obviously the position of the laser, you want it more vertical. You don't want it at an angle because you're going to get more reflection. And certainly if it's off the tissue, it'll depend. Also, which sort of laser you use for which sort of tissue and so on. So I think all that's pretty obvious, isn't it? I think. The other thing is, what I want to say is that as far as using lasers on various tissue, you have different lasers, different wavelengths will determine penetration. So if you had a heading penetration, it's the wavelength that determines how deep the laser gets in. So if you've got superficial structures, you can use a red laser like I just shone on my face. And dermatitis, acupuncture points, in most acupuncture points, any superficial structure, you can use a red laser. Most of the structures that we deal in dentistry, or a lot more of them, are actually inside the tissue, the tonsil scars, a lot of them, some of the ear problems. So if you don't want to go via acupuncture points and you want to get into the jawbone, you use an infrared laser, near infrared. So your wavelength gets into your 780 to about 830 nanometers, and most of them you're seeing on the market are 830. I think it was probably 830 originally because they didn't know what else to use. That was the only ones they had. I just saw some lasers now at 780 nanometers. They're pretty good too. They're getting good results. So I think we've got some work to do yet on which wavelengths are absolutely ideal. But this range of near infrared, you get into, if you look at a 780 nanometer laser, if you shine it on a bit of white paper, you'll see a vague pink glow. So you're just coming out of red into your infrared. So that's the end of the spectrum we're talking about. Okay, so I won't spend a lot of more time on that. If you want to get more information on that sort of things, simply buy a book. Buy a book and get it. Just read it in your own time and go back over it. The Curtin Rose books are pretty good. I think this new one's going to be good too, but it might not arrive for 6 months or something. So the Curtin Rose is the best we got at the moment. I just try to write a book myself, and I'm going through all of that. Everybody who's written books knows what the pleasure of writing books is. But I've done my side of things more on a practitioner's guide because I feel that we're getting enough of these theoretical things available now. We can get more into the practical stuff, and that's what you want in the surgery. Okay, I did a paper about a year ago on development of lasers in Australia. Basically what I said in it was that lasers arrived in Australia 26 years after they were invented. Initially, this was about 1986, so we're talking very recently. The initial lasers were mainly helium neon. They're still 50% of lasers used in Australia are helium neon. Now, you get this situation where you think everything's diode lasers, all these infrared lasers. It's not. Still half lasers are infrared, but are helium neon, but they're going out of fashion. Now, helium neon looks like that first one I shot on my face. Helium neon is at 632 nanometers. It's visible red. It's a great wavelength, but it has no penetration. So you can't get at structures inside the body. Musculoskeletal, nothing there. You're restricted to the surface. So they've changed, and with the development of the new technologies, we've got these diodes they invented originally for CD players, and they are around the 830 nanometers, 780 and so on. So there are a range of these diodes that have gradually been made, and they're the ones now that are being used in the various equipment that we're actually now being able to get for ourselves. Now, I only made one other little comment that I'd like to make on that paper. Those are diode lasers. They're just I could deal with it in a little while, promise. The other thing I just had a little note of there, and it was quite separate from what we're talking about today, is that as soon as you get government restrictions or government regulations on lasers, what we've got in Australia is, so for example, physiotherapists are allowed to use lasers on patients. Where I come from, everybody wants to get in on the paperwork. They all want to have a safety degree. They all want to run things. So you get these government regulations, and lasers have been slow to get into the marketplace. In Queensland, lasers are a part of the physiotherapist degree or certification, and they deal with them as a separate unit. They go into detail. Lasers are widely used in Queensland, and it's why I said to Eric Davis earlier that he can take over for me if I had a bad throat, because he would know everything I'm talking about today. No, mate? Okay. So the different sources, where are we up to? Should we go to have a look at a couple of slides? Yeah, let's have a break and let's keep everybody from too blanketed. We off? Just put. Oh, right. Okay. So we'll just need these lights down a little bit. That's what laser means. That's what the word light amplification by stimulated emission of radiation. Okay, so number 2. Here's essentially, I want to get onto laser equipment in a moment, but here's what a laser, the original helium neons. You've got a chamber of gas to start. You've got mirrors at both ends, one of which is partially reflecting, and you just have a cavity, basically, and you stimulate the gas inside. So this is what happens. You add an energy source, you get a stimulation, the electrons, I'll go into the detail of why you get your laser beam in a moment, but anyway, you get the red lights flashes back and forwards, you reach a certain level, and you get your beam out the end here of your laser. And that's what most of your helium neons have been based on. Just the actual, the band that we're actually talking about as far as wavelengths for lasers, they're mostly visible, and in that area of red, I was talking to Dietrich at lunchtime about blue. Well, that's what we're into, and UV, but at this stage, most lasers are in that red and infrared. Here's your basic laser properties. If I go too fast here, just tell me. I mean, you can get a bit carried away. Just the difference, the fact that light comes out in all directions at the beam, just to emphasise the fact that it is a beam. And just the different things that happens when light hits a tissue surface. And I've got other things that show this same sort of point. Okay, so you get reflection, absorption, transmission, and scattering through a surface. And I've just got a couple more here. I'll just run you through on them, so that when we look at say a 1060 nanometer as compared to a CO2, which is 10,000, the one will go through glass, one won't. And when you see a helium neon in a moment, one will go through blood, whereas the argon, which we were discussing earlier, will actually be absorbed by the blood. So different tissues, these wavelengths are really specific. You know, you think infrared or you think, red, but it's not. It's particular wavelengths in that band that have a particular effect on tissue, and not the rest. And I just put these in because this is just interesting for people to get an image. When you have a laser interactions, as the power goes up, which is on the left, the effect on the tissue changes. So when you have a very high power, you have electromechanical. You blow up a kidney stone in a kidneys. You burn it. Then you photoablation, blow up kidney stones. Thermal just means it gets very hot. And we're talking about the photochemical changes. So we're down that lower edge on power. We're talking about low power rather than any of the other processes which the laser will also do. And here's the same thing again in a different effect. That as you go up temperature-wise on tissue, we're talking about 43, way below 43, but we're talking about biostimulation. So we're down at the bottom rung of the ladder, and all the other stages will cause some damage. Everybody happy with that? That's okay. Okay, and here's the organs. Well, the skin is actually it's vulnerable as well if it was focused, but mainly it's the eyes. And you can get specs. This is class 4 lasers. These are the ones that cut. So I've put a full range of specs in there just so you can get some idea of what the patient and even the practitioner should be wearing. Just the sort of thing that you put on your door, that you put on your equipment, and so forth. And there's one of my patients. Okay, so that should do us for the time being. I've got a space here now, I think. Hang on, what's going on? Okay, all right, we can switch that off for the time being. Thanks. Okay, let's get some light back in here. Everybody's going to probably come back from lunch there, and they're all a bit weighed down, so I don't want to get you too dulled over. Now, what I wanted to do just quickly was go through the various types of laser sources. So we've got through what is a laser light, what is a laser, types of laser. We're heading towards types of lasers now. Now, what I said here initially about the helium neon laser was that the first laser that was a power available for us was the helium neon. It was just a gas-filled tube. They excite the electrons. The electrons jump into higher orbits. Then as they come back into the correct orbit that they started, there is a photon released, and how shall I phrase it? The beams of photons are collected and reflected by the resonant cavities in the tube, so it just goes back and forwards, resulting in a very narrow, parallel, visible red beam emerging from the aperture with a wavelength of 632 nanometers. And that's the one that all of the original work with lasers was done with. Now, that was all that was available up until reasonably recently. Nowadays, what we've got are what are called these diode lasers. Now, the way they can, I won't try and tell you that I know what electronically goes on inside a laser diode. I've read all the stuff, and it's pages thick. From Sharp and Toshiba, I've got all the stuff there, and they discuss valence bands and coherence bands. And what they do is they get a real sort of one molecule thick layer of one particular material, and then they put another molecule just off center on layer on top, and what they call molecular epitaxy, if I remember, molecular beam epitaxy. And so what they're able to do is by varying the distance between these layers that they put together in these diodes, they're able to vary the beam which they're able to get from the material. Now, they use gallium, aluminium, and arsenic. And so they call them gallium, aluminium, arsenide semiconductor diodes. That's what they are. That's the proper name. Now, these guys are good because they're small, they're robust, they're tough. You can drop, my nurses drop them at least once or twice a day onto the floor. Now, if you drop the helium neon, you could fracture the tube, the whole lot perhaps, I suppose. But with these, they're resilient. And they're, there was another thing that came up in Adelaide, that if you wanted 100 milliwatts out of a helium neon laser, you'd need the size of a small cannon to put the energy in to finally get to that power. But to get the same thing from a diode, it's 5 millimeters across. It's a tiny little job. So that's the technological advance that we got now with these recent sort of developments. So I won't bore you with the details here, other than to say that the similar process happens in the diode as happens in the helium neon, and that is that light reflects backwards and forwards inside the diode. It builds up, it comes out through one end, and you get a beam. It's not totally parallel, whereas the helium neon is. It has about a 6% divergence, so it's sometimes you need a small lens in front of your diode if you've just got a handheld job. Something like this would have a as you can see on the end of it, it's got this is a little one we give to patients to take home, and they use it on herpes and that sort of thing, and it's got a little lens on the end just to focus the beam a little bit. Okay. The other thing is, apart from the diodes come in the two forms. They have the continuous wavelength diodes, and this is what you're going to see in most things. Your continuous wavelength is continuous diodes. You'll see it in your P laser. In almost every laser machine, you'll see that somebody tries to sell you it'll be a continuous wavelength, and that's what most of the research has been done on. The pulsed lasers are mostly at wavelengths that haven't been useful, as far as I'm concerned anyway, from a biostimulatory point of view, as much as these continuous wavelengths. But things are changing. So now we're able to look at pulsing lasers. But at this stage, most diodes are still in the continuous wave mode. When I was in Adelaide, I had a look at this computer operator job, and I think you'll see these things too fairly soon. That is that, whereas you've just had these little hand things, for the guy that doesn't want to go through learning where acupuncture points are and all the rest of it, these machines are, and they're only about $6,000 in Australia, $7,000. You just get a laptop computer, and they'll do everything for you. And this guy, how he got through to actually give a lecture that was a sales pitch for about an hour on his piece of equipment, I'll never know. But anyway, everybody wanted one by the time he'd finished. So you can vary everything. The computer will do it all for you. Your power, your wavelength style, your energy, your frequencies. All these things are manipulable. You've got things that will remember how much energy you've actually put into the patient. You've got memories, so that if you did a certain, particularly for the medical practitioner, if you did a procedure for a patient last week and you want to do the same thing next week, you push the button. Mrs. Jones comes up, use these points, off you go, and you don't have to go over it all again and even barely get the card out. You can also find acupuncture points if you want to use points somewhere on the body. Push in the button, stomach 36. Push it in, there it is. So you just don't have to have books and remember all this stuff, And there's other things that you can do, you can punch in that will actually, if you want to do a muscle or tendon problem, you might have a certain pattern energetically you want to use, well, you can push that in at button A, and button A always gives you the right parameters if you want to use certain things. And another one, but button B might be for an inflammatory process or something. So you can do all that. So these things are coming. So in the next couple of years, you'll see them out in this next room here, and they'll be selling you a laser that's got all these whiz bangs on it. Okay, and there's database you can put in and all the rest of it. So from the point of view of actual equipment, that's it. I just run through. I think I've got a few little equipment bits here, and I'll just sort of point out what some of the equipment looks like. Let's go to the. How's everybody going? No, sleep after lunch yet? You don't want a siesta? Okay, alrighty, fire away. Okay, that's a diode. The little funny round bit at the front there is the light coming out, and if you get them, they're tiny little metal bits. You can't believe it that this thing is punching out so much power. As a sideline to this, at the World Conference last year, they had a lot of guys that are involved in the hard laser situation, and the limitation for cutting the hard lasers is that they can't punch enough power into the laser to get it out the other end. About 93% or 95% of power gets lost on the way of the energy that they put into the laser, into these ND YAGs and stuff. So what they're trying to do now is they're trying to get these high-powered diodes to actually wind up the YAGs so that they can go from a maximum output of maybe 3,000 watts when they're cutting to maybe 30,000 watts, which would change things. So, and that may actually put dentistry into a situation where they actually cut tissue. I don't know whether they kill pulps as well, but anyway, that's what a diode looks like. Here's a Clini laser. This is what we made about a couple of years ago in Australia. We just got a simple box. It's got electronics inside. My demands were that I wanted an infrared laser. The best diode we could get at the time was an 830 nanometer and with 100 milliwatt power. We'd been through the procedures, and I'll go through all this a little later, with the other types of powers, but we wanted 100 milliwatt because we tried the rest, and that was what was probably best. The other diode was the other handpiece. In case you don't know what these things look like, I don't know whether this will actually rub off, but I'll show you. No, the diode is actually, with most of the lasers, the diode's right up here. It's just the tiny little bit right at the top of the neck, and All the rest of the whole machine is just a little switching mechanism and power packs. Nothing more than that. This is a good laser because it's almost over-engineered. It's really very good. But that's where the diode is. So it just sits. So all you've got here is you've got a diode here, and you've got nobody's got a laser pointer, have they, with them? No, you've got a diode here, and you've got a diode in here, and then you've got a switching mechanism that switches it on. You've got a joules setting here for between 1 and 6. You really need more than that. And all the rest of the equipment, you've got something to test the machine is actually working, the laser's working. So, but that's what they are. So they're electronically, they're fairly straightforward. And you can work around designs like that. The first thing is, here's a different sort of one, which is handheld. But it's the same design. Basically, you have a diode in here, you have a switching mechanism, and you have removable batteries down there. And these battery packs, they've improved them now. The original ones, they couldn't quite get them to fit. Now they've got them tighter, and things are getting better. But that's almost a P laser, that one there that I showed you, but it's just machined up out of stainless steel. Here's the small little ones that we did. I don't know who I was talking to at lunchtime, but I was talking about a 40 milliwatt laser. If you want one, you can stick a diode in here, just in there. You stick it in with a bit of acrylic, a bit of Tarzan's grip or whatever they have, super glue. And you have a little lens on the front. Here's your diode here, and you have batteries down the tube. This is a tiny little job. It's 40 milliwatts, a hell of an output. And if you want to start off and you're not sure, you don't want to spend $4,000 on a laser or $5,000 on a laser, you can make one of these from Tandy's. Just go and get yourself a little pen light, pull the end of the pen light out, take the lens off, put your diode in there, get your local bloke to fiddle around a bit, and you got yourself a laser, and a full-blown one at that. Your FDA will never know. I don't know. Anyway, that's just a possibility. Nobody would ever do that, of course, and I would never suggest that. Let me just have a look more here. Here's the comparison of the size, like that little one that I showed you earlier, and the handheld rechargeable job, which we use in the clinic. We have about 4 lasers in our clinic, 4 or 5, and all different things. And that should say we make the ideal shape and the laser does the rest. Yeah. Strange. Okay, and we should have a space there, and we should be on to the next. Okay, righto, we can switch that off again there. All right. Okay, now I want to get into this area here, which is the biological effects. So if any of you want to have a sleep, here's your chance, because I want you awake for the rest later on. But this is interesting, I think. One name comes up over and over again on when you talk about lasers, and that's Tina Carew. She's a famous Russian. She's been in this since the early 80s. She's a lovely, one of those sweet, lovely Russian ladies that you get. Big girl, short blonde hair. She'd be in her 60s now. Her funding was cut off last year, I think she was on a world tour to try and scratch up a bit. But anyway, she's a beautiful, lovely woman. And anyway, she's been involved in endless studies on the biochemistry of why lasers work. Now, what they did, and I might have to go back here just to get you exactly right, but what they did was they took various tissues and they exposed them to various wavelengths and so forth over a period of years, and they watched for the changes. Now, to get it exactly, they found when they exposed, say, using a helium neon laser, when they exposed different types of tissues, similar reactions occurred. They used yeasts, they used other sorts of things, not just eukaryocytes, they used bacteria as well. And what they found was they got similar changes in the biochemistry. And they got similar changes over a number of wavelengths. So what they felt was that something which was similar in all of the cells was the photoactive ingredient. So they worked at it, and to cut a long story short, they looked, particularly they found that intracellular AMP changes, and they were able to show, and if anybody wants the papers, Ed's got them, or I can send you a copy and stuff, but the long and the short of it was, they showed that the basic change initially occurs in the mitochondria in the cells, and they get an energy change, that changes the AMP, it changes the calcium in the cell, so you start to get membrane changes, you get an increase in the pH of the cell, and you get changes in the regulation of RNA and DNA, so you get increased proliferation activity in the cells. Now that's summarised something. I've saved you a lot of time there. It's just simply there are certain biological changes which occur when the tissue is exposed to laser, and that's the key to it all. Okay, so let's not spend a lot of time on Carew's work, much as it's just beautiful. It's just fantastic. Let me just give you a little idea. Light is absorbed by the respiratory chain components, flavin dehydrogenases, cytochrome oxidase, and it causes a short-term activation of the respiratory chain and oxidation of the NADH pool. This change leads to changes in the redox status of both mitochondria and cytoplasm, and it goes on to say that there's a lovely chart. You'll see it in all of her papers here, and it just summarises it all down nicely. So let's leave Carew and say that there are enzyme changes. It's all there in detail, and I'm quite happy with that. I think I'm quite happy. Physiologically, what they're saying as well, she came up with a number of conclusions, 6 conclusions at the end of her massive numbers of papers and stuff, but they included things like laser biostimulation is a photobiological phenomenon. So she actually said that you don't need a laser. If you can put light of a certain wavelength into the tissues, she said it spreads so quickly in the tissues that you don't really need a laser for the things she was checking. It didn't make any difference. There are other reasons you would use a laser, but that's not one of them. Number 2, the primary photoacceptors are components of the respiratory chain. This explains the universality of low-power laser effects. Number 3, the respiratory chain components can be the photoacceptors. They are the photoacceptors. Number 4, the light quantum is only a trigger. Number 5, the magnitude of the biostimulation depends on the physiological state of the cell before irradiation. It's really interesting. As they say, during the winter time, when you have a low cell activity, if you stimulate with a laser, you'll get more change than during the height of activity, maybe in the middle of summer. And also, certain other states in the cell will determine how quickly cells will respond to the laser. What it really means is that if you've got healthy cells and you put a laser on them, nothing's going to happen. You can't make the healthier things healthier. But if you've got unhealthy cells and you put the laser beam on them, you get a response determined by the needs of the cells almost. Okay, number 1. There are about 6 of these areas of function, and there's one area I want to get to in a moment. But number 1, that's Tina Carew and all of her biochemical work, and she showed that the mitochondria, the energy production, is affected by lasers. Now, another angle of approach in understanding why the lasers work is the physics. It comes under what I would call physics of absorption, and this is more quantum theory. Everybody loves to hear quantum theory. Basically, let's get very, very briefly. I think I can save you too much pain. The energy of a photon, it's E equals hf. So energy of a photon is given by the equation E equals hf, where f is the frequency, and so on. When you if in a diode that has a wavelength of, say, 1200 nanometers, and we were talking about 660 for the red and infrared about 830, but if we went to 1200 nanometers, the photon energy of the infrared waves of 1200 nanometers is 16.55 times 10 to the minus 20th joules per second. Okay, now, a lot of the scientific guys don't get into these numbers. What they do is they say that one electron, they use terms called electron volts, and 1 electron volt is equal to 1.6 times 10 to the 19 joules. Now, so what we actually do is we get rid of these numbers, and what happens is that we say that a laser that has a wavelength of 1200 nanometers has an actual photon energy. The photon which is coming from the laser has an energy of just over 1 electron volt, 1.034 electron volts. If it's a 600 nanometer laser, the energy of the photon is about 2 electron volts. So what we're talking about energetically is that the lasers, the energy of the lasers in the range that we're talking is between 1 and 2 electron volts. Okay. Now then, if we want to move electrons from shells in various molecules, most electrons from the closer inner shells cannot be shifted with 1 to 2 electron volts. But from the middle out can be. So what we're saying is we're dealing in an energy level where with 1 to 2 electron volts we are quite capable of moving electrons around, creating changes in the molecules which will lead to chemical changes. Okay. That's what that's the essence of the whole deal. So electrons, this resonance energy for the jump needs to be precisely the quantum energy of the incoming photon. So essentially, you've got to use the right wavelength. The photon has to have the right energy to move the electron out. But provided you have that, you get a jump in the electron, and then when the electron returns to its ground state, you get a release of this energy, and it either goes as heat, fluorescence, breaking molecular bonds, causing chemical changes in about 3 ways, or else you get what we call a photoacoustic effect. So you've got these changes that come in directly as a result of the energy of the photon hitting the various molecules. Now, I don't want to... There is another angle here, and bear with me. This is that hydrogen absorbs at 660, oxygen at 630, and you can actually get a singlet oxygen at that level of 1 electron volt. And a lot of the oxidation reduction reactions can occur at this power level of 1 to 2 electron volts. So what I'm saying is that, it's fairly obvious. So anyway, let's not get into too much more there, other than to say that chromophores, cytochromes, and a lot of the molecules, metal ions like copper and iron, and all of these particular substances can be activated by the energy levels available into a 1 to 2 electron volt laser, which is what we're talking about. So we're saying a whole lot of range of activities can occur. The third thing for the biological change caused by lasers. The third thing is to treat light rather than a package of energy like a photon, a quantum. We treat light as a wave. Now, what actually happens is that the light creates a wave pattern. Number one, you'll get various fields created around that, and the same as with needle acupuncture, with TENS equipment and so on, you'll get certain fields and certain changes which occur. Now, what they've shown is that if you use a laser or you use a needle in the tissue, you'll get similar changes. So, they deal with that as being an effect of the field of the needle in the tissues. Secondly, the tissues have proteins which behave like small electrical, or what they call electrets, and like liquid crystals, basically. So what happens is that when you subject them to a field, the proteins change, and we get what's called a photoacoustic effect. You get mechanical changes which change cellular activity. And you also get a certain amount of polarization as the beam goes in, as it scatters, and that creates, there's a particularly important possible change which occurs at the bilipid layers in the cells, where you get changes at the 2 carbon molecules, double bonded, single bonded. So you get a phase transition, and you can get changes there, and also some changes in the ground substance, which I'm going to get to in a little while. So I don't want to go into too much on that one, but you can get effects from both the polarization and both the electrical field that the laser sets up by being an electromagnetic beam. Next, if there's a lovely in Curtin Rose in the book, there is a paper given by Klima from Austria on lasers and why one of the angles he's got involved in research. And what he basically showed was that from a biophysical point of view, you get effectively as if you're doing oxygenation therapy. You get creation of single oxygen molecules which create change, and these can actually affect tissue as well. And there's a lot of other stuff in here. I don't want to get into chaos theory. I think you'll have enough by the end of the day. But it looks like some of the transitional states are affected very much by the laser, and and I think that's a big area, and maybe we'll do that another day. I think the last thing I want to get at, which is number 5, which is its effects on the ground substance. And I think everybody here, with the background that we've all got, will find this interesting, I think. I don't need to remind everybody what ground substance is. Everybody knows it's fibroblasts they secrete the chondroitin, sulfonic acid, hyaluronic acid, other substances. There's large molecules, they're cross-linked. And you get a change between sol and gel depending on a whole lot of factors. And the tissue fluids travel through the ground substance. Wake up, Dietrich. This is your area here. Tissue fluid travels through this ground substance, and embedded in it are capillaries and lymphatics, terminal nerve endings, macrophages, histiocytes, mast cells, and so on, and fibroblasts, which secrete the ground substance. Now, the connecting link between the tissue cells and the closed circulation is the ground substance. Now, nutrients, waste products, bioactive substances must all pass through it. We all know that. Okay. A change in one aspect will cause many other functional changes. At no time can an isolated event occur. Now, Pissinger, as I'm sure everybody's read his book, considers the ability of the ground substance to maintain the status quo as the first line of defence. Okay, and you can get certain substances dumped into the ground substance. You get these mesenchymal blocks and so forth. Now, here's the key, here's the point. Under certain circumstances, the absorption of light photon energy, in other words, the photons from the lasers, can result in the cross-linking in the hyaluronic acid being broken by probably oxygen radicals, which extract the hydrogen atoms from the polymer, break the chain, and the end product of this interaction is water. So, as a result, the colloidal state of the ground substance changes from gel to sol, since the hyaluronic acid is the main component. This one physical change alone can result in changes in permeability of cell membranes and capillaries and in nerve conduction thresholds, and would explain the following effects of laser treatment: anti-inflammatory, analgesic, improved capillary and lymphatic circulation with reduction of swelling. And the ground substance, the primary event, may also be on cell membranes. You've got changes there as well, remember, and you may also get bioactive substances released. So, just to conclude on that, to ground substance, changes in the ground substance restore normal homeostatic function, which then allows organ-specific cells to return to normal function where damage is not irreversible. Thus, the effect of the laser results in connective tissue change with all of the concomitant benefits, including membrane change, and this is quite apart from resonant absorption effects. So, for anybody who likes that, where's Ed? You happy with that, Ed? Okay. Okay. Now, I've got, I want to get onto the clinical side, the dentistry side, and start to make some progress. How am I doing? Pretty good. You all doing all right? Okay. Okay, we're around to clinical effects and dental treatment. That's what I want to get down to now, and I just want to briefly deal the way Kurt and Rose deal with things. It's a nice way of doing it, except they don't explain why things happen the way they are. So I hope that in the last 20 minutes or 15 minutes, by going through the biological effects, that I've been able to save myself having to go, if I say lasers reduce inflammation, or lasers repolarize nerves, or lasers do this, I don't have to say why they do it now, but just leave it as is. So the use of low-level lasers in dentistry can be divided into 4 categories. Number 1, prevention of pain. Number 2, treatment of pain. Number 3, increased healing and regeneration. And number 4, as a diagnostic tool. Okay, so I'll go through them one by one. In a prevention of pain, what they say here is you can prevent after pain that is a common result of several dental procedures like hyperemia of the pulp. If you do root canals, then root canal therapy, and maybe hyperesthesia after periosurgery. And also they add to that if you use a laser before scaling, you'll get less pain, and also you can increase the effects of local analgesics. Now, you know, that's all. You can do a lot more than that, but we'll get to that. So hyperemia, what they basically say is that the cause of the hyperemia after dental procedure can either be mechanical or toxic, and you'll get the increase in pressure and so forth. The the low laser level therapy suppresses the inflammatory reaction and it inhibits the vicious spiral that goes on. What we do in our surgery now, with all this hyperemia of pulps and stuff, we don't get into waiting for patients to call us up and say, hey, you did a filling yesterday, I got pain in this tooth, or it's not settling down as quick as I'd like. Every patient routinely, if they have a deep filling, we use a laser on it because we want to clear any inflammation. This tooth has been chopped around maybe a couple of times over the years. They've had deep fillings. You've got secondary dentine. You've got mercury probably in quantities in the canal itself. You've got electric fields that have been probably high enough to kill major pulpal cells anyway. So you've got a chronically inflamed tissue in most pulps with most fillings that you remove. So use a laser on them. Clear it up. And what I do is, if we're removing fillings by quadrants, say we're removing all the amalgams, we'll do the first quadrant and we'll use the lasers on that after that visit, and also where we put the injection in. And the second visit, we do, say, the lower, whatever the order the quadrant's in, and we'll do those fillings. And then we'll use the laser back on the top quadrant at the same time and also do the lower one. And the third one, if there's anything still problem on the other side, we'll use the laser after treatment there, and we'll go back to these ones and we'll do anything there. So gradually we remove all these chronic inflammations that are showing up in the pulp. So when I get a patient back, say 2 months after the treatment was originally done, I don't get a patient coming in with 6 or 8 teeth that are still chronically inflamed. You've got chronic pulpitis. Who wants that? I saw Crawmer here. Crawmer here was saying, he measured somebody, I think they had about 6 or 8 or 10 chronic pulpitises. He said, take all the teeth out. Hell, the guy freaked. He nearly ran from the place. But that's the point. You don't have to do that anymore. You can clear up stuff as you go along, and a lot of this potential root canal stuff that otherwise would be there in the longer term, you're getting in front of it from square one. Bill?
Don, do you shine the laser at the root tip or on the raw dent before you put the filling?
I do both. I do. If it's a big one and the filling's out, I put the laser directly down through the pulpal floor at the pulp.
How long?
It'll depend on how bad it is, but usually about between 2 and 4 joules of energy. 2 to 4. 2 to 4. Oh, well, it depends on what laser as to how long you use it. So put it down in your book as 2 to 4 joules is probably easier. Say for a 100 milliwatt laser, a minute, probably just under. But then what I do, Bill, at the end is I'll go back to that tooth and I'll go around the root tips and the roots, and I'll get the nurse to do it, root tips both sides, and I'll go at the coronal portion both sides as well. Maybe a joule each side, 2 joules at the bottom maybe. And we don't get any acute pulpitises. It doesn't happen. Or very, very rarely. Almost nobody comes back ever with problems. And this is how you're doing some, with a lot of the work that we do, removing fillings. A lot of these teeth are really compromised, and those that we can't get cleared out right off the mark, what we do is if they're still finding that it's just not getting better, I get them to call up after 2-3 days, and I don't even see them. The patient comes in straight away, and the nurse sees them and puts the laser on the tooth and so on. And usually we'll do it again about 3 days later as well. So it might be 3 and 3 days. And I don't mind, patients can come in as often as they like, as long as I prevent a tooth needing a root canal or dying, a pulp. I don't care if they come in 3 or 4 times, but if I can gradually, and if I find it's not improving, then what I'll do is I'll remove the filling I've put in the tooth. I'll put in a sedative dressing, depending what they're compatible with, and then I'll put the laser back on and I'll leave that sedative dressing for, say, 2 months, and I'll check them again, provided the nerve shows up. If I can test it on the EAV, or you can, normally it's symptomless by that time, but I normally check them with the EAV.
Now, are you talking about an 830?
Yeah. Yeah, you could never get a 660 through a tooth structure. You've got to go to an 830. It would never.
Is this too much?
No, not with what we're talking about. No, I don't think so.
Is this a tooth you had an existing problem with?
No, not necessarily. I do it for every deep filling. But if I had one that wasn't after we did work on, that wasn't clearing up quickly, then I would do it that way. Or if somebody came in with hot and cold sensitivity, and I was going to get onto this in a little while, but let's get at it now. If somebody comes with hot and cold, number one, I'll put the laser around the root. Let's get a little bit of blood flow in there, get a bit of lymph drainage away. So let's get in there first, before I give them the injection. Second, then give them the injection. Third, when you remove the problem, either the filling or the caries, whatever it is, put the laser down inside. Give them a good old burst in there. Clean that stuff out. And then go back after you put in your either temporary dressing or whatever you're going to do, depending what you see. Put your laser back on it again. And if you're not sure, get them back in 2 or 3 days and get your laser to do them, get your nurse to do them again. And just follow it through. Keep on top of it, you know. I don't feel all these patients are nice to you. They don't want to come back to you if they get any sensation, you know. And I look at it the other way. I say if they have the slightest problem and they don't come back, I'm really frustrated. It's good. It's good for the practice too. Patient. If I've got anything like that, crowns or other preparations that have been done on a tooth that are big, I always, well, I mean, during the prep time, then I would do it then. You won't get a laser through most crowns. You'll get them through your ceramic crowns, maybe, probably. I suppose. But we use them on crowns all the time. But certainly you can get at the roots and the apices, yeah. Sure. Anywhere where there's inflammation, you can clear it. You basically clear it. Use your laser to clear inflammation. Think inflammation, and you can clear it.
What's the sterilization procedure on this that you're using so frequently?
The sterilisation procedure, we've been through it over the years. We've just designed it now on the latest one, where we're actually getting disposable tips. And I think that's you can autoclave the tips. The tips can be pulled out and autoclaved. But we've actually got them from Queensland, Eric Davis's place again, but they've got the little optic fibres, and you can actually get them polished each end, so that instead of putting them in a metal tube, sealing them, for about 10 cents, you can get them to cut. This stuff they sell by the mile. You know, with dentists we get had all the time, you know, because they think we're medical, they can charge us triple. This stuff you can get individual little bits chopped off for about 10 cents. So we've got, you know, like on your triple syringes, where you can put the thing in and just screw it up, chuck it away after Seni-tips or whatever. You can get, we're actually now working on that principle, and it's now been done, and I was going to get onto that later, but so we've now got at a stage where, from a sterilisation point of view, the optic fibre just gets pushed up against the diode. The loss is about 30% of power, 25%. So if you start with 100 milliwatts, you're down to about 75, well, maybe 70, that sort of range. But yeah, and disposable. I think that's the only way you go these days. You know, well, other than put things back in the autoclave all the time. So that's painful tooth, and they go on the prevention of pain to go through hyperseizure after after perio surgery, additional pain preventive effects for sore gingiva, inflamed gingiva if you're scaling and so forth. All you're really saying is that if you touch tissue which is really painful and you put a scaler in there or something, of course the patient's going to say it's painful. But if you can actually go in with a laser and you can see the colour of the tissue change from being inflamed, it'll go to a more pink. It actually happens while you're looking at it. Okay, so you reduce bleeding from the gingiva after you do the treatment as well, and you get a faster healing. Increased use of effective local anaesthetics. Okay. Now, that's the first thing, prevention of pain. Treatment of pain, Curtin Rose do a nice little bit in their book. They have lovely little diagrams where you go round and round and round, and the laser affects this, 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 and this. And my view is the diagrams are pretty good. Pretty good, actually. So in pain caused by hyperemia, there's a mechanical or toxic effect, inflammation of the pulp, hyperemia, increased pulp pressure, hypoxia, lymph drainage, the laser's coming here, and direct effect of laser on nerve fibres. So the laser's coming in at all these different points. And that's why it works. It's a nice description. So that's that one. The complications, hyperseizure, for genuine sensitive teeth, I use it the same as I was saying to Bill earlier, just at the time and later. And let's just whiz along through these with fibrositis, myositic pain, those sorts of things. You can use the laser on trigger points. You can use it on attachments of ligaments and tendons. You can use it on the joints as far as an arthritic pains are concerned. And what you're doing all the time is you're reducing inflammation. You're getting more lymph drainage, more blood coming in. Okay, and neuralgias, same thing. Healing for wounds, they love this stuff with lasers. Lasers heal wounds really quickly, wonderful, and they really are. You'll do surgery that should take 10 to 14 days to heal, and it'll be healed in 5. I mean, and you'll see it happening. You can get the patients back for suture removals at 5 to 7 days. I mean, May scopes might get them back to 7 or 9, but you just see the tissue is. But what I also do at the same time with surgery, I should also comment, is that usually before we do any surgery, if we have the choice, we've removed fillings, we've got the tonsils right, got all the drainage side of things right, we use homeopathics at the same time, but the laser's just an adjunct.
How about dry sockets?
You don't see them. Haven't seen a dry socket for 3.5 years. Don't see them. And that's honest, believe it or not. The other thing you like, what I've got here is during surgery there's less bleeding. Post-operatively you get less swelling, less pain, faster recovery after surgery. You get, it says here, prevention of dry socket. And also prevent hyperacidic teeth. Hyperacidic? Anyway, the other thing is, and I tell you it's nice, is this effect on neural injuries. Because I get a whole lot of people that are, they've had damaged lingual nerve or whatever, infradental nerve, and they'll come in and see us, say, I had this wisdom tooth out a year ago, and my lip's still numb, and my tongue's half numb, and so you start off, you go in at the insertion point and where the nerve goes in and comes out, say for example on an infradental, and you'll go to the actual problem area, and it takes you about 6 goes, but you'll get 70% maybe of people who have got numb lips will find that the sensation will come back. It's a gem. It's a gem, I tell you. Probably a month. Yeah, about 6 visits, about a week apart. I'd say 2 visits the first week, then once a week after that. And it's really good. And if you do some surgery and there's a bit of bruising on one of the nerves and the patient's not sure, or you may have damaged it, and they say, hey, my lip's still a bit tingly, and you use the laser immediately. It's good. There was a great study on rats where they crushed, lovely animal experiments, they crushed the sciatic nerve on both legs of a rat. One side they didn't use laser, the other side they did. And they found that the sensation in the nerve, even though it was totally crushed, was never lost in the nerve they exposed to laser. But on the other side, it took some months to regenerate. So it's really cool. It's good. It's good. You're going to probably have to use a fair bit on that. Yeah, maybe 10. 10 by the time you go, maybe 2 out, 2 going in, maybe 3 or 4 along the actual nerve itself, maybe the area on the bone itself where the surgery was done, maybe a couple of joules there. The diagnostic use of the P laser, you can use these lasers. I don't do it much myself now, but you can use them. If your person comes in, and the theory of it is that if your patient comes in and says, I've got a pain, I don't know where it is, I've got a painful tooth, I don't know which tooth it is, you can put the laser along the various roots of each tooth and you just move it in little circles. And as you move it in little circles, the patient says, I'm getting a prickly effect, it's getting worse, and determined by the amount of time that it takes for that to occur, determines the fact that the sudden increase in blood pressure into the chamber of the tooth has caused a pressure build up and the patient experiences pain. I don't use it much, but maybe Ed does, I don't know. He might be able to tell you more about that. Okay, so clinically, that's just an overview of healing. Let's get on to clinical use of low-level lasers in dentistry. Okay, so what have I got in that? We'll get to the slides in a while. So I'll just go through different types of conditions to make sure I haven't forgotten anything. We'll get actually onto the dentistry. What have I got here? Most modern low-level lasers used in dentistry utilise a diode with a wavelength of between 810 and 830 nanometers, which is infrared, with a power output of up to 100 milliwatts. Some systems have a second probe where there's a diode of about 660 to 680 nanometers, which is in the visual red, and a power output of up to about 30 milliwatts. Now, the reason for this dual probe approach is that while the infrared diode is very good for problems which are deeper in the tissue and has excellent penetration and may also be used for superficial situations, the visible red laser is the choice for superficial situations. But you find, believe it or not, the further you get down, the more you use your infrared. You use your red less and less and less. Okay. So for gingival treatment, if the problem is, if the inflammation is superficial, I use a visible red laser, mostly. 1 to 2 joules for a papilla. If I'm doing a couple of papillas, I might go on 5 joules for 5 papillas. I just put the laser on, maybe inside and outside, depending what the problem is. If it's deeper tissue and I feel there's pockets, bony pockets around there, I'll switch over and use an infrared. So you just think like that. If it's deeper, I need penetration, give me an infrared. If it's shallow, red. Acute inflammation, 1 to 2 joules per papilla. And then what I'll do is I'll get, if people are in an acute situation, I'll usually bring them back every 2 days. Maybe 1 or 2 days. Assess them at 2 days. If they need to come back again, they'll be better. If you think a little bit more would help, bring them back in another 2 days. And then maybe another week. You don't have to do it yourself. I've seen how Bill Wolfe works. I mean, he doesn't do anything. All his nurses do all his work for him. So, I mean, you can get your nurses doing it all, you know. God, I learned a lot when I went down there. Now then, cold sores, abscess, ulcers, same story. The patients at my surgery, our surgery, sorry Simon, the patient at our surgery, if they get an abscess ulcer or a herpes, they call us straight away. They know to call us. They just get on, if they feel the prickling that occurs before, they just ring up, come down. The deal is they come down to see a nurse straight away, put the beam on the cold sore, and if we can get it before it bursts, it's not going to burst. They can come back the following day and the day after. And these, I'll show you a cold sore. One of my mates took a few sides for me, and he's using a P laser himself. And you'll see the healing over a period of 2 days with a cold sore, and rather than 14 days like some of them take to heal. Pericoronitis, same story. Use it on the flap and the musculature in the tonsil area, and you'll get some very quick resolution of these sorts of swellings and inflammations. Pericoronitis, yeah, I'd say about 4 to 6. Yeah, no rush on them. You can keep the laser on them for quite a while. You'll see it changing while you're doing it. They'll go from red to pink. It happens. Pulp testing, we've gone through pulpal problems, hot and cold, and what I said about just the ongoing treatment on a daily basis. What I've written down here is don't mess around. Prevention of root canal treatment is paramount. Remember that what the tooth has been through. So direct pulp caving and so forth. So the other thing I should say, I've said about surgery, tooth extraction, rat in the bone cavities. We don't do much surgery on rat in the bone cavities now. With the lasers, we've found it by EAV testing before and after, we usually have to do it a couple of times because where you've got this sort of scar tissue in the bone, it doesn't change overnight. So you might have to do it once, do it in another week after that, maybe a month after that. But I get the girls to do that. But that's good. We're finding that when you look at the X-rays, as I was saying to Ed earlier, with the OPGs maybe 2 years later in 8 sites, you see the bones back. You don't have to got those dark chambers anywhere. And once in a while you still have to do a bit of surgery, but not real often. Patients like that too. Periodontal surgery, same. Soft tissue lesion removal, old scar tissue. We're in the same thing, 2 to 4 joules, 6 joules, that sort of thing. Paresthesia, damaged nerves, same thing as I said earlier. Hypersensitive teeth, you've got to correct the reason, but a couple of joules on each root. And orthodontics, when I have kids having, if they have to have wires, well then basically I'll get them back maybe during my maximum period of movement. I'll get them back every month, maybe every 2 weeks, every month, a couple of months, and I just go around the roots of the teeth, and just to make sure that none of the ortho bloke isn't doing too much damage to that bone around those kids. So we just keep in front of it, so you don't get a problem. TMJ problems, same. I said it earlier. You can work on origins of muscles and all the rest of it. Now, tonsillitis, if we've got an acute tonsillitis, I might go up to 10 joules on something like that, 6 to 10, and I might get them back in 2 days and do it again. Same with sinus problems. You can actually get at your maxillary sinus using your 830 direct, or you can go to your acupuncture points to get there indirect. But either way, you can get at the sinuses, the sinus floors. So for chronic or acute tonsillitis, do it today. All your stuff, your cell proliferation takes 2 to 3 days. So to get your maximum benefit, if you've got a certain number of cells there and you've got a chronic situation that's fibrous, you'll double your cells 2 to 3 days later, basically, give or take a bit. So if you do your laser 2 or 3 days after your initial, then do it again, say another 3 days later. The action is much greater after the second go, and then you can do it again after that. But you're getting back towards maybe what the original numbers of cells were. So tonsillitis, ear problems. We do loads of kids with middle ear infections, inflammations. We just put it on either the acupuncture points behind the ear or directly on the mastoid and so on. And I'll try and show you that a little bit later. And tonsils at the same visit, sinuses and interference fields. How are we doing? 4 o'clock. Good. I'm an hour and a half? Right, this is going to be my 5-minute interference field presentation. After I get this, there's another area which I think is also interesting with lasers. When I was at the conference last year, Ed Wong did with Garrett Lee. Garrett Lee? Lee Garrett or Garrett Lee? Do you know? Garrett Lee, is it? Garrett Lee spoke on low-level lasers for about 3/4 of an hour, then Ed spoke for about half an hour or 3/4 of an hour on whiplash injuries and how to use lasers and try and get reattachment of ligaments that have been pulled out. So they have it, I'm sure you all know it, but you can get further details from Ed at any time, I'm sure. But you know, they do a whiplash injury comes into your surgery, the guy says, I still get pain around the neck. You palpate the styloid, you palpate C1 at the transverse processes to find out where the damage has been done, nuchal line, occipital protuberance, and then go down your spinous projections around your medial spinal ligament down the centre of the spine, find out where the real damage has been done, usually maybe T12, somewhere down there, and check your upper medial points on your scapulars to find out whether the ligament, whether the muscle was, the trapezius was torn out of there. Check your shoulder attachments for your trapezius. Just, you know, there's a technique of palpating around. If you can find where the damage has taken place, you've got all your bradykinins, your potassium, all this stuff is stopping the healing going on. So what they do is they put on the 100 milliwatt laser, the lymph increases, it drains all the junk out, and all of a sudden you've got a chance of healing on some of these muscle attachments. So if you can do that, and then they just get some tape and they put a big 3-inch tape from the back of the neck down to the rear end and then across the scapula, like the shape of a cross, it just immobilises the patient slightly. And what happens is 3 days later the patient comes in, they take the tape off, they check again. If there's still pain there, they do a bit more laser, another bit of tape. They do it 2 or 3 times, and they find they get a lot of healing of whiplash patients. And it's something you can do. I mean, I get patients come in. It's worth a try. And at least even if in a limited sort of way, you know. Okay. Yeah, love it. I use EAV a lot more with that, though. I want to find out why the trigeminal neuralgias occurred. And usually there's an interference field in the jawbone. A lot of times. So if I get rid of that, often the neuralgia just goes. But I use the laser in conjunction to get regulation of the nervous system back, for sure. I get a lot of patients referred with trigeminal neuralgia. Okay, Dietrich, here it is, interference fields. What I'm going to say basically, and I want to get down, I'll cut all the stuff about how we got to where we got to. But basically this, a patient comes to my surgery, we do a diagnostic workup initially with electroacupuncture and other techniques, of course, OPGs and all the rest. If they're there for fillings removal or whatever they've come to see us about, that's all done. Then they get back to see me about 6 weeks to 2 months later after the fillings have been removed. Now, I call it my biocheck visit. Now, what I do at that visit, I want to find out if there's any problems remaining. Now that the smoke screen or the screen of the heavy metals is gone, I can get a really clear picture of what's happening with all the various other parts of the jaw. So I go to the acupuncture points of the lymph meridian. And I start off and I go to the point related to tonsils, ears, 5 tonsils, tubal tonsil, jaw point, eye, and sinuses and nasal vault on both thumbs. So I take a measurement, I measure also the indicator drops, and I write that down. And I also write down the allergy point, CMP allergy. And I'll show you why later on. Then what I do is I start off, and the girls do it all for me. I go for a walk. I come back in about 20 minutes. I don't know what the rules are here, but I go for a walk, and I just see another patient. And the girls know more about this than I do these days. And one of them suggested she should be coming instead of me. Anyway, so what we do is we usually start with the tonsils, and I'll show you when we do this demonstration in a moment. And usually we don't even go in early on, and I'll show you with the slides, and we'll whiz through those. Early on, we used to do laser inside the mouth and get at the tonsils over the tongue and around the. Now we just put it behind the corner of the mouth, just down here. Just put your P laser or your Clini laser, whatever you want to use, down here, and it'll just clear that tonsil. Just go down to your deep lymph nodes as well. 6 to 10 joules on that one. Yeah, either side. I mean, you're on it sometimes for quite a long time. So, and because with most people, the tonsils are the big key blocker. So, yes, sometimes. Yeah, Yeah. So tonsils first. And we've got them open, things will start to work. And you'll find the tonsil acupuncture point will go back to 50, no indicator drop. And by doing that, you'll find a number of, if you wanted to get, just to follow it through, and if you just did the tonsils, checked all your other points, you'd find that a lot of your other points would be better, although they wouldn't be down to 50 yet. So then what we do is we go to the ear, and we go to the 6 points behind the ear. And I've got them marked on the slides. And they're up, it's from about the level of the external meatus. The top point is up here, and you've got a couple of 5 points, and then you've got one down on the bottom of the mastoid. So I get the nurse to use, but we don't use the 660, which you'd think on acupuncture points, because we're also getting a benefit from actually getting into the mastoid process and around, where there's still often inflammation from when kids have had problems when they're 2, 3, 4 years old. They've had middle ear infections that never really cleared, and you can pick it up. I think every kid in the schoolyard should be lined up at 10 years of age and have their tonsils and ears done, because this stuff is still showing up when they're 40. So we go through and we just do the ears. And then if you wanted to, you could recheck the ear point till it was 50, and you could show what other points had changed. But we just get on with it. We do the tonsils first. The girls do that to what they presume from the initial readings was required. Then we do the ears, both sides. Then we go, usually they're the 2 key areas. We'll go on then to, if I found an indicator drop on sinus point, I'll do the sinus points as well. Usually the 4 points, and depends a little bit. But usually we'll do the 4 points, put the laser on the actual acupuncture points, 1, latitude 2, so they're 1, where are we? Colon 20, 3 up here with where the cartilage and the soft tissue of the nose meets, and 4, corner of the eye, bottom of the nose, that's the maxillary point. So those 4 points, we use those only for a short time, 20 seconds maybe on that. You're talking acupuncture points. Acupuncture points need very little stimulation. You can get through them in, short time. But if you're going structurally, that's different. You might need a couple of minutes. So you'll do those, and then so you've picked up tonsils, you picked up ears, you picked up sinuses. When you go back then to your eye points, your eye points will normally be pretty balanced. You won't normally have to touch that, and it leaves you your jaw point. So what I've usually done is by the time I've got the patients arrived, by doing things what I said earlier, a quadrant at a time, and sorting out any interference fields as we go along, usually the jaw point doesn't need anything, unbelievably so. But if it does, or if the jaw point hasn't come down, what I do is I've got the OPG out there. We've looked at any deep work that was done. We check symptom-wise with the patient. We look for any areas that we've done before and we maybe need to do a little extra on. I get the nurse to do that on the day. And I walk back into surgery. I expect every acupuncture point to read 50. No indicator drop. I expect it. And I used to check them 2 weeks, 4 weeks, 8 weeks, 16 weeks, so on. For something like a year, I just doubled it just to make sure that these things held. And you get 85, 90% of your patients. You won't have to touch them again. They stay at 50. It's great. It's great. Who needs interference fields? Dietrich? Got any questions? Okay. All right. So we've done the interference fields. And what I want to do before I go through the slides, I just want to quickly do 2 little areas. Number one is that we're getting beyond a little bit of this interference field stuff now. What we're trying to do is we're trying to integrate other types of treatment. So for the ears, we're starting to use, if we do tonsil work, we do a little bit of a few ear points too, where the tonsils are. I haven't got these on slides and stuff, but you can get your diagram of an ear, and if you want to look at tonsil points, there's 1, 2, there's about 4 tonsil points around the place. There are other areas for jawbone on the ear, and they're pretty straightforward areas, and you can pick up pretty easy. So it's just a matter of, you might want to just top up what you've done health-wise everywhere else, just give a little bit else extra here. If you get a patient with a sore throat, and this is what we'll have in our practitioner's guide, but you'll do the tonsils inside the mouth with your half a dozen, 6 to 10 joules. You'll go down maybe to colon 4 because it's your accumulation point of head and neck, hoku, so you'll do that, and you might add a few other points, lung 11 or something, but just as sort of distal points, and you might do other points around the face as well. So I think we can move through to that phase, particularly with lasers, because the average guy doesn't. If you haven't used needles, it's particularly on the face. You're running for a litigation. So, but if you can use stuff inside the mouth, ear points, phase points, distal points. We're really making some progress, I reckon. Yeah, so that's where we're going at the moment. That's what we're trying to do. And then last but not least, so I've got a few diagrams of acupuncture points around the face, and they're all available now. Anybody can get them, you know. And we're trying to get all that sort of. The other thing is, is that as anybody who's been involved with acupuncture knows, and with electroacupuncture in particular, there was a lot of work done with certain. The body resonates at certain frequencies, and certain types of problems respond to certain frequencies better. And Nojia's got work on it, and other guys have got work on it. And what we're trying to do is with the new lasers, we're trying to pulse to certain the laser beam at certain problems and see if it makes any difference, or whether we just get the same effect that we always got with a continuous beam. So we don't know yet, but that's underway right now. And the last thing we did, and I'll show you on the slide, is where we can actually put into that pulsing beam the homeopathic remedies, and we've just seen whether that makes much difference, and it seems to. But we're not sure about that. Louder, here we go. Then I'll stop talking. We can get on to it. So, geez, we've got to. I won't waste too much time on these. So that's low-level lasers. If anybody wants to write that down, it's fine, but I'll just continue otherwise. Where are we?
What's NBT?
Say again?
NBT.
No idea. Let me have a look.
35 degrees. 36.
Near body temperature or something like that. Something to do with body temperature. Yeah. Normal body temperature. Yeah. These were kindly donated, some of these slides, by a friend of mine, Paul Drummond. So I must thank him for that. He's starting to do a bit of lecturing, which helps me out a lot. So you've got your effects, and there's another one that also covers more of the effects. So you can actually sit down and discuss each of these things if you want to conduct it. But this is what I said. This gets on down into here, you know. So you can, if you want to conduct any meeting that you've got, you can get the slides out and go straight to here. This is what most dentists want to hear. They want to get onto the clinical side. They don't want the biochemical details, and this is nice. He's done a good job on all of this. Fantastic job, actually. The power density, and just how you get those joules per square centimetre, and you've got your watts per square centimetre, and so forth. But we went through all that. Joules, effective total dose in joules, and net dose, and so forth. We right? Okay, so that gets through that bit. Then I want to get on to, here's the herpes. Now, this was on Paul's daughter. The actual herpes runs from up here down to there, on my memory says. Where are we? Yeah, it runs, it's along there, comes down around here. I don't know whether you can see it, but it's, so he uses, this is one afternoon, he puts the laser on it tonight. A laser on it, and now he takes another picture. That's the laser's just been on it for about 4 to 6 joules. Okay, now, next morning, he puts the laser on it again. Same afternoon, the kid comes home. He puts the laser on it again. This is 1.5 days, like that, and then there's the next morning, I think. Yeah, it's just about gone. Okay, and I just showed a laser there, so you know what you'd be doing. Back to some. Now, this guy had a whole lot of surgery both sides there, and you can see the bruising and stuff. He puts it later. Now, 3 days later, she comes in. I hope you can see a difference there. It was when I looked at it first, it looked like the swelling has gone down, the colour's a lot better. She's got a bit of colour back in her cheeks. I didn't want to get into too many clinical things. Here's a lady, this is not one of my patients, it's one of his. My apologies for a few of the things that, you know. Anyway, she's a lovely lady. What he tells me is that she had an accident where she strained her TMJ muscles and so on. So that was one of his original photographs of her. Then she has an accident, and let's get a picture of what she was. That's what she was like. That was her jaw position. And he does laser on the muscles, and you'll see the position from there back to what he gets with at the time in the surgery. Yeah, it's just great, you know. Like this is like 2 or 3 minutes later, where she's closing now. I just put that on trigger points just to show with one of our little lasers. This is like years ago, that laser, just to show what you're doing around the TMJ. These were sort of, and these are just some of the points. That's the two jaw points. But you can get all these from your EAV books. And there's the way Vol sort of shows them in his books. The two jaw points, you can see them there, gallbladder 3 and so on. And I'll just continue. There's one other one of my patients. That's a little hairy-nosed wombat. That's the South Australian symbol. And now we're working on teeth and up around the apices of teeth. And I just wanted to show how we do it. I don't do it much like that now, but and with different types of lasers and some gum work. No, that's a sterilisable tip, but we still put those sheaths over and we tried it out. And these are the books. This is the Curtin Rose book. And there's the Shiro's book. Shiro's book, I didn't actually get around to mentioning anaesthesia. We're working on that too. There's a section in this book here. What we've done now is we've taken the bilays, the latest lasers we can pulse, and a Shiro, he's got a section in his book that's from China, and they reckon they've got 7,000 patients where they, in 4 minutes of putting a laser on Jiaqi down here, they numb the lower jaw, and 2 points on the top jaw up here, just put 1 centimetre directly below the orbit and one under the malar. If you use those 2 points, they reckon anywhere you can extract a tooth within 4 minutes just by putting these laser beams onto these points on the top jaw. So I hope that made sense. So they're saying 4 minutes of this. So we've just got these pulsing lasers, and we're going at it. When I get back, we'll be trying it out over the next few weeks. Because if we can numb a jaw in 4 minutes to the point where we can extract a tooth and we can use one acupuncture point down here, that's a hell of a lot better than putting in a chemical substance back around for a block. So we'll see how we go, and I'll tell you about that later on, maybe at a future time. But this looks encouraging because we've got the lasers now that will do it. So what the story is this basically: I want to numb the lower jaw. I put the beam, and you'll see it on one of the slides. The beam on Jiaqi here, about 1 centimetre up from the corner. I put it on there for 4 minutes, or else I get the nurse to get a point locator, put it on the point. She puts the laser beam on here. When I come in to do the work, the laser beam gets shifted down to colon 4, which is in that web between the thumb and the first finger, and she continues that while we do the work, and the numbness continues for about 20 minutes after. That's the story. I used to use needles in London back in the early days, and we used to take 35 to 40 minutes to get a patient numb, and they looked like a porcupine by the time we finished. We had 2 needles in each ear, and we had 5 or 6 sticking out of the face, and we had cords going. So if this works with 4 minutes, I'm going to be a changed man, I tell you. I'll be using it for sure. Now, here we go. That was our original way of doing tonsils. It's very hard work. More tonsils, ear points, showing a few of the points behind the ear and the deep lymph node points. More ear points. More ear points. More ear points.
Do you get much of tinnitus?
Yeah, get a lot of that. Usually find I get rid of a lot of that with the removal of fillings if I've got a high currents back there. But if I don't get rid of that, then often the ear points will help with that as a direct measure. Just use it even apart from changing any fillings over. Just use it as direct on those ear points. Sinus points there, the 4 sinus points, and other ways of using sinus points. Ear points, jaw points. Everybody knows the jaw points for Vol. There they are there, the 4 points around the mouth. Just, if you get it and you're not sure where, there's still the lymph 2 won't come down and everything else has come down. Well, check those 4 points with your dermatron, find out where your indicator drop occurs, then go inside the mouth. You can test each tooth. I mean, if you want to get simple, you can just get them to put the finger on it, but just you can test it and you find it quite quickly. Love it. Well, I thought I got most of them up the right way. I didn't check that one. So that was just a dermatron checking a point. Now, and showing a high reading, and I'm just going around those jaw points. I left all the dermatron points out, slides out. We test, for if we want to, we'll actually find out. This is getting into this newer stuff that we're doing. If we are not sure, if we think there's a chronic pulpitis or a kyphrostitis required around a root, we'll find out how many ampules of homeopathics are required to balance it. And then we can actually take those ampules and put them in the honeycomb, which is in the laser circuit. So we actually oscillate that stuff down. So maybe the angle I'm getting at is that I might at present be getting healing within 2 or 3 days. I want it, if I can get it in 10 minutes. Hopefully we can. That's early days yet on that. So you can see now we've got Oh, the dermatron's just showing a balance with a homeopathics in circuit. Yeah, I had to work hard to get that 50. And then I've got these last couple of slides here. Here's the bilays, the latest one, and the nurse is just putting some homeopathics into the laser beam. We're just putting the laser on the point. The laser was just put onto the point.
Who makes that unit, the
Oh, it's out in Australia at the moment, and it's just the local guy that I work with. He's got a manufacturing. He's got a company out there. So I'm actually clinical director of his laser company, that side of it. But I'm sure you could get something done here. I'll sort out something with it anyway in the end, for that. Here's the anaesthetic side of things. So we've got it so we can actually, that's a 660 nanometer. So I've done everything the Chinese have told me to do right. I got it collimated. It's the right power. In fact, it's slightly more power than what they've been using. So if I can't get 4 minutes, I only got this about 2 days before I left. I didn't have a chance to tie one of my nurses down and actually force her to go through this procedure to see whether there's any pain. But I'll do it as soon as I get back, I promise, and I'll fax over the results. So that's Jiachi, and that's the sort of, that's all you got. You got a nurse sitting there for theoretically 4 minutes. Then she calls you, she sticks a probe into the gum, and the gum goes numb. The patient says, I can't feel that. Well, the tooth theoretically is ready to, have whatever work done on it. So that's the anaesthetic, and then that's just moving it down to colon 4. It's just after the, that should be it. Oh, we're back to square one. Okay, so we can get the demonstration organised. And how am I doing? 10 minutes I got? I hope. 14? 15, okay. Let's at least show you in part what can be done. Okay, so whatever has to be moved in, let's move it in. I don't know. What do we do, Ed? I want to keep back from it so I don't look like I'm cheating. Yeah, probably. Somebody who's had their fillings out, detoxified, and whoever, you're welcome to come out. Yeah. There's other books around there. I think you got cheated.
Have you ever been able to eliminate the wearing of glasses by stimulating
Yeah, I don't. Also, getting rid of fillings sometimes does it too, a bit. But as long as we get the acupuncture points back to 50 for the eyes, I'm usually pretty happy. But I wouldn't say I would be, relying on the things changing. No. Roy Martinez doing a bit of stuff on soft lasers and stuff. So I haven't got through his tapes yet, but they arrived the other day. We got some other guys. One of the local boys out where I am has done some musculoskeletal stuff on lasers. That's good too. Oh yeah, I'll talk to Ed later. See what I can organise. And this is the one that I'm working on, but that's going to take me another 3 months yet to finish up. That's a practitioner's guide. It's nothing like, unless you want to do.
They kicked my recorder off.
I hope there's nothing there I can trip on. Oh, sorry, get out of your way. Go down all the lymph points from tonsil, ear, 5 tonsil if you like, tubal tonsil, jaw point, and even eye for me if you wouldn't mind, eye and sinus and nasal vault. And CMP, yeah, allergy control. If I can have those both hands. Yeah, all that can go. Yeah, and of course he's got all this stuff on the screen anyway, so I thought I might have to write it down, but I don't. How you doing?
Fine.
Okay. Well,
And the control measurement point here.
for allergies.
Allergies. Same ball wax, 50 with indicator drop.
Drop. Okay, so where were the biggest indicator drops?
Lymph tube was the only significant difference.
What and what about tonsils and sinuses and jaw and ear?
They were all about the same. They were all about 50 with about the same improvement.
Okay, about 50. Really?
Well,
Okay.
yeah.
Simon, do you want to do some laser? Do it anyway, mate. Ed will show you how to use the P laser. Just give them about a minute or two behind, on the tonsil point and just behind the ears, and we won't worry about sinus points. Just ears and tonsils and see what happens. I reckon. If you, is that okay? I've put the P laser by the just by the machine there, so just. Ed will have to show you how to work it, but.
You might mention when you use that acupuncture anesthesia that it doesn't numb the gum or the lingual nerve.
Mm-hmm.
You need to infiltrate that a little
Mm-hmm.
bit.
Yeah.
It does the tooth great, but it doesn't work on the gum or the gingiva.
We're in for some fun.
I'll let you do this time because it's going to be on film.
No, that's all right.
No, I don't want to.
Oh, okay. Right. Okay. All right. Yep. How do I work this one? Just squeeze it 2 times. And how do I switch it off? Yeah, okay. All right. So normally we would go here. We'd start on the tonsil point. Is it going now? So it should. Okay, give it another go. So we're going. Turn your head just around a little bit. So most of the tonsil areas you can get at best from there. Okay, I'll do one side anyway, if not the both sides. And you just sit there for about 2 minutes. 2 minutes. Just let it work. And he'll actually feel it. If he's got any sensitivity towards acupuncture when he's here, he'll actually show it.
What kind of a sensation? Warm?
No, not normally. Just tingling maybe, or just sometimes it's sort of like a flooding almost. This will be about 30 or 40, so it'll take a while. Yeah.
Because of the fiber optic.
Yeah, lose a bit in there. At least I'll show you the procedure, and then if you guys want to do it later on anybody, then you get stuck into it. So we would do on that, if anybody wants to see it, we would do the tonsil area there, mainly there, because we're looking for either tonsils or tonsil scars, so we'll pick it up on the inside. Then normally my nurses will actually run down. Is that got to cut off or? All right, and then we'd actually move down here, depending on what the lymph nodes are like, just here. And we would have tested those just with a little palpation before we start. And then we come up behind the ears. He'd actually, I won't do any face points because I don't have any protective specs, but the points are up at the top here, a couple of points, and there's a few back a little bit, and then you're down onto your mastoid. So normally my nurses will palpate the mastoid to start, and they'll start there. And I'll leave it there, and then they'll do that for about a minute and a half. And then we'll come up to the other points, and they'll just move over those over the next about minute after that, 2 minutes maybe. And then they'll start, if we need to do sinuses, we'll do it. Otherwise, we'll go straight inside the mouth, and we'll do the individual teeth that have still got a problem. No, don't worry about it. Not anymore. Okay, how do I... Right. So that's basically how it's done, and you can remeasure those if you like, just see where you are. But it's probably needs another 15 minutes. But at least it's an overview. See, if you still find your lymph 2 isn't balanced, then you can go around now and you can look for why.
drop it limit too.
Yeah. So if you want to just run around his four. So run around his just his face points for me, if you like, with the probe, and just see which of them still has the indicator drop.
Okay, I don't use
Whatever you wish. Otherwise, I'll get him to touch him or something. Just because one of those quadrants will have an indicator drop.
Yeah, I don't know which
Okay. Whatever you wish. If you want to look for say an interference field in a part of the jaw, if you want to get him to find that, then put the laser on it for say 2 minutes, and we'll bring that back to 52, and it'll be right tomorrow too. It won't have gone. Is that okay? I mean, we've got 50 on 50 on tonsils. We've got 50 on ears. We've got So I mean, this. Yeah. You'll keep. I mean, I did spend a minute and a half, I suppose. Thanks, Carol. That was nice. Thank you all very much. Okay.
But then the next thing is, where do you get some of those lasers?
I'll sort something else later. Here's your mic down here.
Washington, D.C. He's a 1986 graduate of Boston University, and he's stationed in Washington, D.C., and he's working with corporations and health organizations and different things to change the political and the legal climate. He'd like to have a few minutes.
Actually, I'm in a better place than D.C. I'm in Los Angeles. People think Hollywood's surreal. If you've never been to Washington, D.C., then you really don't understand what surreal is like. They have a phrase it's called inside the Beltway. Inside the Beltway, things are totally different. Last spring we had a conference here, and at one of the evening get-togethers, somebody made a comment that I found very telling, and kind of was rather heartbreaking. They said, we used to be able to get together and just talk about technique and have a good time and share good things, and now we have to talk about politics and the law. And I'm really sorry that that has to be the case and that I even have to be standing up here today, but it's a rather unfortunate reality. One of the things I've learned from representing alternative, actually what I'm trying to call progressive practitioners, is that preventing a situation from happening is a heck of a lot easier, a lot cheaper, and a lot less painful than letting it happen and having to deal with a full-blown problem. So I'm trying to practice preventive law. With a little bit of help, I think we can do that. Bill Moore, who I worked with very closely for a year, and we're still in very close contact. We simply became too busy in each of our practices. Gave me a phrase, OPELL, Opal. And y'all have something that I've made out of that. It's the Opal Facts, National Facts Update sitting in front of you. OPAL stands for Organization, Publication, Education, Legislation, and Litigation. If you address a problem in those 5 areas, you can really make an impact, and that's what I'm trying to do. So, and one of the means of doing that, to increase organization, to increase education and people's involvement, is by sending out this fax. About 30 of you, 35 of you signed up for the fax network. Some of you are already on it. If the rest of you would like to join, it's a means of increasing the communication, because I don't see that many people on a daily basis, but you guys do. So you can really help spread the word, and things are happening. They're happening very fast. One of the things I have here, we're selling bumper stickers just to try and spread the word. The dietary supplement issue, 40% of the American population, a multi-billion-dollar industry that's growing in a time of recession, and we were only able to make the national TV media 2 weeks ago. It's been going on for over a year. Let you have an idea of what we're up against. Everyone else they're well financed, they're really good, they have lots of people, we're all volunteers. I think I'm one of the few lawyers in the country on this issue who volunteers his time in all of this and pays for things out of his own pocket. On the FDA and the dietary supplement issue, yes, they want to take amino acids, herbs, and high-potency vitamins off the market. They've said that. They will do that if we don't stop them. Good news is we've got a Hatch and the Richardson bill, which have a lot of support in the Senate, and there's still about 60, 70 co-sponsors short in the House. Bad news is both of those bills have serious flaws and need to be rewritten. So there's still a lot of work. We'll see what happens there. California law enforcement really fast. The chiropractic board has started cracking down on chiropractors who are using homeopathy. It's too detailed to go into in my 5 minutes, so I'll just hang out. And if you want to talk to me, ask about it. Informed consent as far as dentists go. We pushed a bill through last year that was supposed to allow for patients to be informed before getting fillings about the dangers of mercury amalgam. The dental board, of course, whitewashed the whole thing and approved an informed consent form that made no mention of that or any of the other potential hazardous materials they put in people's mouths. Healthcare reform. Healthcare reform offers lots of potential, but you have to be organized and you have to be involved to take advantage of it. There's a two-sided sheet of paper that's floating about, everyone should have, that discusses some of the terms, some of the possibilities. If you want to make it happen, contact me. My number's on it. People have been talking about devices. I'm sorry that I'm going so fast. They only gave me 5 minutes. I really need about half an hour. And I know everyone's ready for their break. Devices. The FDA has jurisdiction from the manufacturer down to the retailer over any devices used in healthcare, period. Okay, now you can try and argue semantics about it, and I imagine that the reason that they're not going after light therapy the way they're going after laser therapy is that laser sounds a lot more dangerous and a lot more high-tech, and light therapy sounds a little more new agey. But they could if they wanted to. Just because they're not after you or you've been doing something for 20 or 30 years doesn't mean it's safe. It means that they haven't bothered or they haven't heard about you yet. They are undermanned. They are underfunded. Bless them for that, and I hope it stays that way. EAV, well, there are continually problems with that. As long as a device is sold as something that's non-medical, it's okay. If a device is registered as a biofeedback device, like Eclosion is, then that's okay, as long as they make no mention of any other uses during the sale. Once it's in the practitioner's hands, and the FDA is arguing about this, but they can't beat the Supreme Court in some of their own regulations. Once it's in the practitioner's hands, it's the practice of medicine, and they have no jurisdiction over it. The problem is they're talking to the boards, and they're getting the boards all hotted up about it, saying they're not supposed to be doing this, and they're hurting people or defrauding them. So we need to work on that some. And between Bill Moore and some other people and myself, I think we're going to have some positive results after a long, hard fight about it. It scares the living daylights out of them. We've got an industry that's built up almost $900 billion as a total, and they like it that way. They don't want to change that. You think the dietary supplement issue is tough. That's only $4 billion in sales total. We're talking about $900 billion when it comes to healthcare reform and healthcare generally. And you guys are the way of the future. You have inexpensive ways of dealing with major chronic problems that they really don't know how to deal with. It's non-toxic. The rate of iatrogenic problems is minuscule. That scares them because they see what they're doing is going to be just eliminated. We've got a couple rules to pass around. I hate to do this, but because I am trying to work in this area, I'm not paid by anybody to do this. This is something that I do just as a public service. If people can contribute, that's great. It helps pay for the phone bills. I have yet to make a profit on any of this and doubt that I ever will, because every dollar I get goes back out into travel expenses, pamphleteering. I don't know if you're familiar with pamphleteering, but that's how the American Revolution happened. People passed pamphlets around. Do it, spread the word. We're having fundraisers. We've got some more videos that'll be coming out. I don't know if y'all have seen the one with that Pat Mooney did with Mel Gibson. It's called Raid. It's a 60-second spot. check it out. If call Citizens for Health, they can get you a copy. I put them, Pat Mooney, in contact with some people in Hollywood. We now have videotapes with Whoopi Goldberg, with Eddie Alpert, with Randy Travis, and others. These have all been distributed to Congress in about a 50-minute format, and that will hopefully help change the way things are going. Healthcare reform promises, like I said, to be a really major issue. Every licensed provider will have to be included. And the nice thing is, if it goes the way Clinton's plan does, and there's no guarantee that it will, the people who will be in charge of buying, well, there will be two bits. There will be health alliances, regional alliances. That will be the patients and the people who are paying for it, the business people. How would you like to have the person deciding whether you get insurance be the person who receives the care and understands how good it is, and the person who understands that they're paying less in the long term than they were for these other people, so they're saving money? That's a very positive aspect. Okay, 5 minutes are up. If anyone would like to talk to me, I'll be here for the rest of the day. I've got meetings down in LA I've got to get back to. The fight will go on. Thank you very much for your time. And we've got bumper stickers.
I just wanted to give you the name of two companies that I've bought surplus lasers. They do not sell, they do not know anything about what we're doing. They're selling them mostly for laser light shows and things like that, but they are in the power range that we're looking for. But what you need to know first is you need to know the power range that you're looking for and the, the color, the light spectrum that you're looking for. Okay, they can't help you at all on that. They know nothing about that, but they're very good prices, often 10 times or better than you could normally buy good quality lasers for. Anyway, the two companies that I've had good results that have helped me are Meredith, MEREDITH Instruments, and I will try to get a phone number tonight. I don't have one. Their address is P.O. Box 1724, Glendale, Arizona, and the zip is 85301. The other one is simply called MWK, and they're in Corona, California. It's a 909 area code, and I don't have a phone number for them. I'll try to get it tonight. MWK. Or it might be MWK Lasers, perhaps, I don't know. But they move a lot of merchandise, and what they have one month they won't have the next month. They don't inventory a lot, they sell a lot, and they have very good prices. And it's a very fast-moving industry, and if you tell them what you're looking for, you may call once a month. Do you want a purple laser? Do you want a pink laser, an orange laser? And sometimes they have them, and sometimes they don't. But I found them to be very reliable. I've never had any trouble with any of them. Yes?
So you call and ask for red or infrared, or what do you ask for? What do you call?
You have to know what to ask for.
I'm saying, what do you ask them?
Well, I'm using them for other purposes than this purpose. I'm doing some research stuff with crystals, subtle energy technologies. So I have quite a few different colors. But anyway, these are good people, and if they don't have it, ask them if they know anybody, and often they will